Okay, let's talk about chapter 40, gastrointestinal system drugs. So there are a bunch of different types of gastrointestinal drugs that we're going to talk about. Today, we're going to talk about 7 in this chapter, chapter 40. We're going to talk about antacids. We're going to talk about H2RAs, which are histamine 2 receptor antagonists. And we're going to talk about PPIs, proton pump inhibitors, and then some miscellaneous acid reducers that we can use, GI stimulants, antiemetics, and emetics. We're going to talk about like their actions, their uses, etc. So just to get us started, there is a little bit of concept. H. pylori, it's a bacteria that grows in the tummy and in the first part of the small intestine known as the duodenum, and it can cause something called peptic ulcer, right? When it gets out of control. H. pylori can cause peptic ulcer disease. And we know that a lot of different medications, H2RAs, PPIs, and acids can help H. pylori bacteria, but they can't treat it. Only antibiotics can treat it since it's a bacteria. Okay, so digging into these drugs, antacids is the first class of drug, and the action of antacids is to neutralize or reduce the acidity of the stomach by increasing the pH, right? So examples of antacids include calcium carbonate, magnesium hydroxide, and aluminum carbonate. Uses for antacids, maybe you've got some heartburn, some indigestion after eating a nice greasy pizza, some gastroesophageal reflux disease or GERD reflux, right? Or peptic ulcer. Antacids are going to help to neutralize the acidity so that ulcer can heal, right? Adverse reactions to antacids, maybe some constipation, some diarrhea, weakness, anorexia, potentially nausea and vomiting. Since a lot of these are calcium-based, maybe hypercalcemia or too much calcium in your blood, headache, and potentially kidney stones due to that increased calcium as well. Who shouldn't take this? Contraindications, abdominal pain of unknown cause. So if they don't know why your belly hurts, you probably shouldn't take an antacid. It might be something serious. If you're lactating, if you have heart problems, if you currently have kidney stones, or you currently have high levels of calcium in your blood, this is not the med for you. We want to be careful in clients that have upper GI bleeding, have decreased kidney function, or any type of respiratory insufficiency. And then interactions include digoxin, isoniazid, and phenytoin, and also chlorpromazine. All of those can decrease the effect of antacids, and antacids can decrease the effect of these medications. Tetracycline decreases the effect of that antibiotic tetracycline. So yeah, that's not good, right? We want the antibiotics to work. Corticosteroids actually decrease the effect, and then aspirin is going to increase the excretion of aspirin if we take antacids. So it's going to be excreted faster. So those are antacids. Let's move on to H2RAs, those H2 receptor antagonists, okay? Histamine 2 receptor antagonists like ranitidine, famotidine, cimetidine, all your tadines, right? So your Pepcid, right? These decrease acid in the stomach as well. And they help with heartburn, indigestion, GERD, ulcers, and also hypersecretory disorders or hypersecretion, where our tummy is just producing way too much acid. Dizziness, headache, confusion, diarrhea, hallucinations are probably not great side effects, but they are adverse reactions related to H2RAs. If you're allergic, you probably shouldn't take it. And then we want to be careful in people with renal or hepatic issues, the elderly, people who have diabetes, and the pregnant or lactating mamas. Interactions include antacids or metoclopramide, which is Reglan, because they're going to decrease the absorption of H2RAs. Carmazine is going to decrease the white blood cell count. So that's not good. Opioids with our H2RAs can increase the risk of respiratory depression. Anticoagulants with our H2RAs, ranitidine, famotidine, cimetidine, are going to increase the risk of bleeding. So things like warfarin, no good. And then digoxin is going to increase the serum level of digoxin, and that is also bad. We don't want dig toxicity. Okay, so that is H2RAs in a nutshell. You guys do have all of these notes uploaded in the classroom if you want to review them. PPIs, proton pump inhibitors, super common medication. Pantoprazole, omeprazole, lansoprazole, right? So protonics, that's a big one. These decrease gastric acid by targeting the parietal cells directly. It helps with ulcers, reflux, or GERD, right? Hypersecretory disorders, prevent bleeding in clients on anticoagulants as well. So that's good. Adverse effects include headache, nausea, diarrhea, and abdominal pain. Don't want to use it if you're allergic or pregnant. PPIs are not for pregnant women. Also want to be careful in the elderly and those with hepatic issues. Mixing this with sucralfate is actually going to decrease the absorption of the PPI, so no good. Ketoconazole and ampicillin. So ketoconazole and ampicillin, these are going to decrease the effectiveness of the anti-infective because of decreased absorption. Anticoagulants mixed with PPIs like pantoprazole, omeprazole, and lansoprazole are going to increase your risk of bleeding. Bisphosphonates, usually prescribed for people that have like recurrent fractures or osteoporosis, is going to actually increase the risk of fractures. So no PPIs with our bisphosphonates. And then digoxin, increased absorption of digoxin, potential digoxin toxicity. Benzodiazepines and phenytoin are going to increase the level of the anti-seizure drug. So really, really decrease central nervous system. And then clarithromycin is going to increase the level of clarithromycin if we mix it with a PPI. Okay, miscellaneous acid reducers. There's 3 of them over here that are kind of random. I guess 4 technically, but 3 categories. Various info, obviously it's very specific to the type since this is just like the potpourri category, right? So there are cholinergic blocking drugs we can use to reduce gastric motility and decrease the amount of acid that's secreted. Common ones include propanthyline and then glycopyrrolate. Glycopyrrolate and propanthyline are cholinergic blocking drugs that reduce gastric motility and decrease stomach acid. Pepsin inhibitor, like sucralfate or carafate, it binds with the protein molecules and forms that really viscous substance that buffers the acid and protects the mucosal lining. This is the only one that's going to coat the stomach, right? It's going to coat the stomach, sucralfate. We also use sucralfate for other things, which we'll talk about in just a hot minute. And then misoprostol or Cytotec. It's commonly used for induction or abortion. It's a prostaglandin drug. It reduces the risk of non-steroidal anti-inflammatory drug-induced gastric ulcers in high-risk patients. So might use that as well. Okay, GI stimulants. These increase GI motility. The big one, metoclopramide or Reglan. Remember, this is for reflux or GI stasis. The tummy is not moving the right way or not moving there fast enough. We need to increase peristalsis, right? Increase motility. Tardive dyskinesia. Remember that? Involuntary rhythmic movements of the tongue, the chewing, the mouth, maybe even the peripheral body parts like your arms or your legs. That's tardive dyskinesia. Also, anxiety, depression, dizziness, or drowsiness can occur when taking metoclopramide or Reglan, a GI stimulant. Shouldn't take it if you're allergic. Definitely not if you have an obstruction or perforation in your GI tract. Moving things along faster is not going to help if you've got a big clog in there or it's broken open into your body. Hemorrhage, if you're bleeding, right? If you have a tumor on your adrenal gland, pheochromocytoma, if you have seizure disorder or you have Parkinson's disease, let's not use a GI stimulant. And then be careful if you've got diabetes, you've got heart disease, you're pregnant, or you're lactating. And then interactions include anticholinergics because they're going to decrease the effect, obviously, because cholinergics and cholinergics are going to increase motility. Anticholinergics are going to decrease motility. So they're going to be working in opposite directions. Cimetidine is going to decrease the absorption of cimetidine when you combine with metoclopramide. Digoxin is going to decrease the absorption of digoxin, that important heart med, when you combine with metoclopramide. MAOIs, high risk for hypertensive crisis. So we don't mix MAOIs with metoclopramide. And then the last one is levodopa. It's going to decrease the efficacy of both the stimulant and levodopa if we combine them. Okay. Antiemetics. So there are 4 types of antiemetics, okay? So there's the miscellaneous category, and dronabinol is the big one, right? Dronabinol is a derivative of an illicit substance. I forget the name of it, actually. It's marijuana, but I'm trying to think of like the actual isolated compound that makes the dronabinol. But regardless, it's going to help with emesis, right? It's going to help prevent emesis or vomiting. Antidopaminergics like chlorpromazine or promethazine, right, are going to help with nausea or vomiting to prevent vomiting and reduce the nausea. Anticholinergic drugs like tromethobenzamide, and then 5-HT3 receptor antagonists. This is your Zofran, ondansetron, Zofran. We use these before surgery to prevent nausea, to help with any nausea that's currently existing as well. We use it in post-op recovery. We use it with just general nausea or with anti-nausea neoplastic drug nausea, radiation nausea, or pregnancy-related nausea. Adverse effects include drowsiness, prolonged QT with like ondansetron, the Zofran medication. You can have some cardiac arrhythmia with that. Contraindications include allergy, if you already have CNS depression, because some of these can make you pretty sleepy, bone marrow depression, blood dyscrasias, Parkinson's disease, severe liver or heart disease. Precautions include glaucoma, GI obstruction, hypertension, sleep apnea, epilepsy, or electrolyte imbalance. And then interactions, you don't want to mix these with CNS depressants because of increased sedation. We don't want to mix these with antihistamines because of increased risk of those adverse anticholinergic effects, right? Like dry mouth, extreme dry mouth, extreme constipation, etc. Mixing with antacids actually decreases the absorption of the antiemetic itself, so it's not going to work very well. Mixing with rifampin, specifically ondansetron, is going to decrease the effect of that Zofran. And then mixing with lithium is going to increase the risk of those extra pyramidal effects, all those additives, specifically like tardive dyskinesia type symptoms. No, thank you, right? Let's try to stay away from those. So if antiemetics are against vomiting, emetics encourage vomiting, right? The big one is syrup of ipecac. So syrup of ipecac used to be purchased over the counter. Now it's no longer available over the counter because it needs to be given in the with the supervision of medical staff. It induces vomiting. Emetics are medications used to empty the stomach rapidly when an individual has accidentally or intentionally ingested a poison or drug overdose, right? So definitely something that needs to be monitored because it's going to induce vomiting. So add PI for all of our upper GI drugs. Get a history of the symptoms. Write down or document the number of times that the patient has vomited. Get some vital signs, baseline vital signs. Assess their fluid balance. Get some labs on their electrolytes. Look at those suckers. See if they've got sodium or chloride disturbances. If they have kidney issues related to prolonged dehydration. Watch for signs and symptoms of GI bleed. Get some daily weights on your patient and do some strict I's and O's. Right? Strict I's and O's. Diagnoses that might be assigned to your patient include risk for deficient fluid volume due to diarrhea, nausea, or vomiting, imbalanced nutrition, less than body requirements due to the impaired ability to get food in and keep it down, individual effective self-health management due to inability to take an oral form of medication, and then risk for injury related to the adverse effects of medication, specifically drowsiness or dizziness may make you fall, right? Risk for injury. And then planning, what do we want to see? Well, we want to see the optimal response, the expected outcome, right? What we want to see from the medication. So if it's an emetic, that's vomiting. If it's an antiemetic, that's the ceasing of vomiting, right? We want to support our patients' needs related to managing those adverse reactions and preventing them if possible. And we want our client to understand and comply with our drug regimen. So what do we do? Interventions for the implementation part of the nursing process. We want to give an anti-nausea medication before the client goes to chemo or surgery. That way it's effective during chemo and after surgery. We also want to monitor their I's and O's and record at least every 8 hours. And that's going to depend on the severity of the symptoms and the unit policy. We want to watch for diarrhea or signs and symptoms of dehydration, like low blood pressure, tachycardia, etc. Interventions to increase their appetite, offering them preferential foods, small frequent meals, finger foods if possible, maybe a different consistency in order to meet their nutritional needs. Get that call light in reach and watch for signs and symptoms of tardive dyskinesia development, especially if your client is taking Reglan or metoclopramide. We want to monitor that cardiac strip for QT prolongation and potential arrhythmia. And we want to teach the client no driving, especially if they're on one of those medications like Phenergan that might make them sleepy. Okay, evaluation. How do we know we were successful? Well, the client produced the expected response, right? We got the optimal response to the medication. There was no injury, so there was some understanding. There was compliance of the client. There was no adverse effects, and if there were, we managed those correctly. So a couple questions, and obviously you can see the answers. So let's just talk through them. The upper GI system includes the mouth, esophagus, and stomach. We take in foods and fluids that are processed and absorbed for the use in our cells. Yes, that's correct. Upper GI system, mouth, esophagus, stomach. That's the upper GI. Next one, hydrochloric acid is secreted in the esophagus to help in the digestive process. Well, of course not. Hydrochloric acid is in the stomach. Stomach is where the hydrochloric acid is to break down our food. And the last one says problems occur when the digestive juices, I guess there's 4. The third one says problems occur when the digestive juices reverse and go into the esophagus or backflow into the stomach from the large intestine. That is false. Now, this is really tricky. Only one word is wrong. It's not the large intestine, it's the small intestine. So remember that the esophagus connects to the stomach connects to the small intestine. So if there was a backflow, it would be from the small intestine into the stomach, not the large. Large is last. Large, last. You start small, you get large. So the small comes before the large intestine, right? Okay. And then the truly last question here, question 4, antacids do not actually coat the stomach. Instead, they neutralize acid in the stomach. And that is true. Antacids neutralize acid. Caraphate or sucralfate actually does not neutralize the acid. It coats the stomach to protect the stomach. Okay. I think that's it for upper GI medications. I will see you guys in lower GI medications.